We are happy to introduce Walid Al-Nahal, who is our mentor today, who is going to talk about acetabular fracture. This is a difficult topic to understand your own and reading it from the book, because it takes a lot of three-dimensional thinking in a complex structure, which is the pelvis and the acetabulum. Before we get to the talk, may I remind everyone of the etiquette of this meeting. Please keep your mics muted until you are allowed to talk, please. In addition, please check our website for the forthcoming webinars. We have renewed the we have, put a new face to the website so that you can register directly from the website for the coming webinars. In addition, you can check our book, which is very good preparation for the exam. Mr. Al-Nahal is a lecturer at Cairo University. He has come to the UK in 2017, passing his FRCS exam. And since then, he has done several fellowships in arthroplasty, pelvic and acetabular fracture. And now he is doing one fellowship in young adult hip surgery in Birmingham. Without further ado, I would leave you to with Mr. Al-Nahal. Now, sorry, I forgot to mention, this lecture will be interactive. We need volunteers of you to answer the questions during the lecture. These will be interpretation of the X-ray mostly, and they are not designed to grill you or to test you. It is just to help everyone understand the concept better. If you are interested in volunteering for that, please just raise the hand and I would pick that up. Please, everyone take your hand down, because raising hand means you want to volunteer for the interactive part of the lecture. If you want to contribute to the Viva session at the end, I would like you to chat directly to Shwan in the chat function with the word Viva. So if you want a Viva, chat to Shwan with Viva. If you want the interactive part of the lecture, raise your hand. Okay, thank you. Now I've got so far 3 people, and without further ado, leave you with Mr. Al-Nahal.
Thank you, FRCS Mentor Group, for giving me this opportunity to present this lecture. So I think fractures of the acetabulum is one of the topics a lot of us worry about when we are revising our trauma for the FRCS exam. I think mainly that's because it involves a lot of 3D sort of thinking, and just as Abdullah mentioned, just trying to make sense of it without having experienced them could be a bit tricky. What we'll try to do today is we'll quickly touch on the mechanism of injury and clinical assessment. I won't spend a lot of time in the theoretical bit, because most of us can read that on our own, and most of us already know about that. What I'll try mostly to focus on is the radiological assessment and maybe the classification for the Viva part of the FRCS. For the FRCS, we don't need to know a lot of details, but we just need to know the basics, and that's what we'll try to cover. Surgical approaches, they could be quite complex, and decision-making could be quite complex. Again, we're not going to go through them in a complex way. We'll just highlight the principles, just so that in a Viva you could feel comfortable, and you could demonstrate that you have the basic knowledge for these types of injuries. We'll quickly touch on the outcomes and complications. So mechanism of injury, I think we all know these are high energy injuries, 80% of them being road traffic injuries, and 10% fall from height. And the reason why we have this very wide variety of fracture configuration is that the fracture configuration depends on where the head of the femur was and how the force came onto the head of the femur. So you can see that from this diagram, you can have hundreds of possibilities depending on where the head was and how the force was subjected onto the head. But we are seeing low energy trauma in elderly, and these are very different types of fractures from the high energy ones. We're not going to discuss them today, but just so we know that yes, they do follow the same general guidelines as the young low energy fractures, but they are a different population and a different fracture pattern. They tend to involve the anterior column more. There tend to be a lot of comminution and articular impaction in these fractures, and we have different management goals when we are trying to treat these fractures. So you will see later on that with the young high energy trauma, we aim for anatomical reduction. We aim for, like any articular fracture, early range of motion and so on. With these, we treat them more like an elderly neck of femur patient, where we want functional restoration, we want to get them up, we want MDT input on their comorbidities and so on. So it's, if we are confronted in a viva with an elderly 80-year-old fracture, just put that in mind, that this is another totally different mindset from the one we'll be discussing for the rest of the lecture. Clinical assessment, like any high energy trauma, you need to mention that you will make sure that you go through the ATLS guidelines. You have to point out that these acetabular fractures have high incidence of associated injuries, and this is usually dealt with in the major trauma center. They usually are they usually go through a trauma CT scan, getting a CT of the head, chest, pelvis, and so on, like any other high energy injury. A particular sort of clinical assessment scenario, which is popular in the viva for acetabular fractures, is the dislocated hip. And it's more of a classic scenario than a common scenario. It's usually you're presented with this x-ray with a dislocated hip, where you go through the ATLS, associated injuries and so on, and then you point out your concern about this dislocated hip, this being a surgical emergency, and that you need to point out that I need to reduce this. So why do you need to reduce this on a sort of an emergency basis? Well, I'm worried about the sciatic nerve being compromised. I'm worried about the blood supply to the femoral head, and that leaving it in a dislocated position might lead to AVN later on. I'm concerned about the articular cartilage compromise, with the head being out of the socket and possibly rubbing against the bone and so on. Where do you reduce this? Do you reduce this in the emergency department, or do you take him to theaters? You definitely should be taking him to theaters. He should be generally anesthetized. Muscles should be relaxed. And how to reduce this? Your assistant should be stabilizing the pelvis. You should be putting traction on the femur in a sort of a flexed position. Before doing so, you need to obtain appropriate consent. You need to document the neurovascular status. After doing so, you need to again document the neurovascular status, the sciatic nerve, and you need to comment on the stability. And then, another sort of classic question after that is, what if you can't reduce it in the middle of the night if you're in a DGH? Would you open this, or would you abandon? I think, that you could answer it in different ways. What I would say is that I would abandon, because I don't have the capabilities or the expertise to deal with this in the middle of the night in the DGH. I would phone the major trauma center or the specialized center which deal with these, and I would follow their advice. I would suspect that they would ask us to put some sort of skeletal traction on, and then transfer them to their unit. They might choose to do it in the middle of the night. They might choose to do it the next morning, because attempting to do so, if it's non-reducible, I could be doing damage to the femoral head and so on if I persist on trying to reduce it. Then we go to the radiological assessment, and this is where it gets a bit tricky, and this is where we want to spend some time. So historically speaking, and probably in the 40s and 50s, when the orthopedic surgeons were presented with these fractures, they didn't really understand what was going on. And I'm speaking to some of the very senior surgeons. Their thought back then was that the head somehow broke through the floor of the acetabulum and just landed into the pelvis. And that's why the treatment back then was just to put them in traction and get that head back. And that's basically, what people understood about it. Then came two pioneers, really, Judea and Luternell, and they transformed the way people think about this. So they proposed this column theory, and they said, well, the acetabulum is an anterior column and it's a posterior column. They form a triangle together, and these columns are basically supporting the acetabulum. So you've got the anterior column, which is in white here, which is the front of the ilium, the front of the acetabulum, and the superior pubic ramus. You've got the posterior column, which is red, and this is the greater sciatic notch, the lesser sciatic notch, and the ischium. And these two columns are what hold the acetabulum together. Between these columns, you've got the anterior wall, you've got the posterior wall, and you've got the medial wall of the floor in between. And then they wanted to make sense of the X-ray. So they came up with this very, brilliant yet very simple idea where they got some lead markers and they put it on a cadaver or on a bone. And they put it on the anterior column, they put it on the posterior column and on the walls of the acetabulum, and they took an X-ray, and this X-ray is from their original book. I think it was published 1962. I don't really remember the exact date, but this is the picture they took so that they could start making sense of these fractures. And then they came up with the lines, the Luternell lines, which is again a sort of a classic Viva scenario where you're presented with these X-rays and given a pen and you're asked to draw these lines. So what they came up with was the iliopictoneal lines. So the iliopictoneal line represents the anterior column of the acetabulum. They came up with the ilioischial line that represents the posterior column. If we go back to the iliopictoneal, so it starts from the superior pubic ramus, heading upwards all the way to the SI joint. Look at the ilioischial line that starts from the top of the inferior pubic ramus, going up to the SI joint. So when you're drawing them, just start from the superior pubic ramus or the inferior pubic ramus, then you're heading up. Then there's the teardrop, which I think a lot of us might be familiar of from hip replacements because we use it as a landmark. And this represents the medial wall or the floor of the acetabulum. Then we've got the roof or the dome. And then we've got the anterior wall and the posterior wall. And because we know that the acetabulum is anteverted, the anterior wall lies more medial than the posterior wall. Posterior wall, you can start by tracing it from the back or from the lower border of the inferior pubic ramus going upwards. The anterior wall, you can start drawing it from the lower border of the superior pubic ramus, then going upwards. Okay, so again, this maybe was good in understanding what these fractures were, but they wanted some more sort of 3D representation. So they came up with these Judet views. The Judet views are basically oblique views, whereas you can see the patient lies in an oblique matter, 30 to 45 degrees, and the beam goes perpendicular. So they came up with these views, and the one in front of you is called the obturator oblique view. Obturator, because you can see the obturator foramen right in front of you, and the obturator foramen, you see the iliopictoneal line right in front of you, and that represents the anterior column of the acetabulum. And then if you look backwards, you can see this line. This line is the posterior wall line, and that represents the posterior wall. So the obturator oblique view, which you can see the O or the obturator foramen right in front of you, that's the anterior column, iliopictoneal line, and the margin of the posterior wall. If you go to the other side, that's the iliac oblique, where you see the ilium right in front of you, you can see this, which is the ilioischial line that represents the posterior column of the acetabulum and the anterior wall. So they're sort of opposite to one another. So the iliac oblique, where you see the ilium right in front of you, that's where you see the ilioischial line, that's the posterior column, and the anterior wall of the acetabulum. So this then led to the Luternell classification, which a lot of us have problems sort of making sense of. So there are two main categories. We've got the elementary fractures and the associated fractures. Elementary means that we're dealing with one fracture line or one fracture. Associated means that is a combination of fractures. We'll try to simply go through them one by one. The posterior wall fracture, maybe a lot of us are familiar with, is where the posterior wall gets broken off the acetabulum. What would we expect to see on an X-ray? Well, the posterior wall line, which we just drew, would be disrupted. And some of them are associated with dislocation of the hip. Now, these views we talked about, the obturator views and the iliac oblique view, if you remember, it was the obturator view which showed us the anterior column and the posterior wall. So even though this fracture was reduced, you can still see the posterior wall fragment quite clearly on the obturator view, but on the iliac view, the one after it, you can't see it clearly because it actually shows you the posterior column, not the posterior wall. So what about, oh, sorry. What about the CT scan? So if we look at the CT scan, if we look at the hip without the fracture, the one on the left, if you look, these corners here, these are the columns. And then the wall, we've got the anterior wall, posterior wall, and the floor. So if there's a break in the corner, that's a column fracture. If there's a break in the margins, that's a wall fracture. And you can see here that you've got a break in the margin here, so that's a posterior wall fracture. And that white arrow is pointing to what we call marginal impaction. So normally, the articular cartilage here would be facing the head, but because this has been impacted by the head on its way out of the joint, it is now facing towards the back of the acetabulum rather than facing towards the joint. So this is marginal impaction, and this we will talk about later on, is one of the predictors of poor outcome. So we've got a posterior column fracture, which, as the name might suggest, it's a fracture of the posterior column. And on an X-ray, it's the ilioischial line that will be disrupted. And you can see here on this iliac oblique view that you've got a disruption in the ilioischial line. What about the CT? Remember, we said this is the corner that's going to be fractured on the CT scan. And the CT scan here also shows you a dent in the head. This is some impaction of the head or some femoral head damage. Again, another marker of poor prognosis. And this is the column fracture, the posterior column fracture. Then we've got the anterior column fracture. Again, as the name might suggest. And where would we see it? We would see it on the obturator oblique view, again, a disruption in the iliopectineal line. And on the CT scan, it's the anterior margin that, oh, sorry, yeah, the anterior corner or the anterior column that is going to show the fracture line. Then we've got this transverse fracture. And the transverse fracture is basically one fracture line going from the front to the back of the acetabulum. That's why it's an elementary fracture, because it's one fracture line. That fracture breaks the anterior wall, the anterior column, the medial wall, the posterior column, and the posterior wall. So it goes through the whole of the acetabulum, but it is one fracture line. So that might be some confusion, maybe something that could be mentioned in the MCQ. Is this an elementary or is this a associated? It is an elementary because it is one fracture line, and it could be further divided according to its location, but that's not something, at FRCS sort of level. If you look at the X-ray, you're going to find a disruption in all of the lines we drew: the iliopectineal, the ilioischial, the anterior wall, the posterior wall, but it remains one fracture line cutting the acetabulum into two, one top bit and one lower bit. On the CT scan, what would you expect to see? Well, it's not in the column, it's not in the wall, but it is one fracture line passing through all of them from front to back. So we'd expect a line going from front to back here. Of course, a fracture is never a straight line, it's always an irregular line. So when you actually look at the CT, you will see something like this, one line going from front to back. That's a transverse fracture of the acetabulum. So then we come to the associated fractures, which is where it gets a bit complex. So it's basically combining these fractures together. We've got a transverse posterior wall. So we already know what a transverse fracture is. It's one line going from front to back. So it is the same, but we add to it a posterior wall. So if you look at the lines, you will find all the lines disrupted, but on the obturator oblique view, where you can see the obturator foramen, you can see a disruption of the iliopectineal line, because we know the anterior column is broken, and you can see this here, which is the posterior wall fragment broken off. What about the T fracture? A T fracture is another variant of the transverse. So again, one fracture line from front to back, but there is a fracture propagating downwards. That fracture propagating downwards goes all the way down to the pubic bone, and thus it separates that transverse into a front bit and a posterior bit. So it's a T fracture. So you would expect on the X-ray for it to look like a transverse fracture, one fracture line going from front to back, but there's an additional fracture here in the pubic bone. So by definition, again, another point maybe for the MCQ is, what is the definition of a T fracture? Well, it's a transverse fracture plus a fracture in the pubic bone. So there's your main fracture line, and that's the pubic fracture. Of course, this pubic fracture is propagating from up all the way down to the bottom, but you won't see that propagation on the X-ray. You will be able to see it on a CT scan. So on a CT scan, it will have fracture going from front to back and one transversing downwards to the pubic bone. What about the posterior wall, posterior column, posterior wall? Again, a posterior column fracture, which we can see on the ilioischial line being disrupted, plus a posterior wall fracture you could see on the obturator view being separated. You can see here how the head is dislocated or subluxed. So on a CT scan, if you you might have already noticed by now that on a CT scan, you've got your transverse fracture going from front to back. You've got your column fractures going from medial to lateral. We come to the big guy here, which is the both column fracture. Both column fractures, as the name might suggest, you've got a fracture of the anterior column and the posterior column. But it's not only that. The main hallmark of the both column fracture is that the dome or the acetabulum is no longer connected to an intact part of the ilium, or no longer connected to the axial skeleton. Again, this is another sort of MCQ question. So by definition, both column fracture is a fracture of both columns of the acetabulum, where the dome or the acetabulum is floating or is no longer connected to the rest of the axial skeleton. And if you look at this X-ray, it might, look confusing, but if you take it one step at a time, you'll notice that the iliopectineal line is disrupted. You'll notice that the ilioischial line is disrupted. So we have both columns here broken off. And if you look at what's going on the ilium, you can see fractures basically everywhere here in the ilium. And if you trace these fractures, you'll notice that the acetabulum or the dome is no longer connected to the rest of the axial skeleton. So by definition, again, this is a both column fracture. To complicate things a bit more, there's the anterior column posterior hemitransverse. From my point of view, or from what I've experienced from the FRCS sort of scenario, I wouldn't really worry about this fracture. It's sort of the both columns' little sister, if you could say. The main difference really between this fracture and the both column fracture is you can see that part of the dome is still connected with the rest of the axial skeleton. So it's not a both column fracture. It will be very difficult to differentiate in an exam scenario whether this is a both column or whether this is an anterior column posterior hemitransverse without having a CT 3D dimension. So I wouldn't really worry about this fracture, and particularly that its treatment principles are more or less the same as a both column fracture. So if we can get all of this information just by looking at X-rays, then why do we do CT scans then? And that is another, possible Viva sort of question. Why bother if you've given me sort of the whole classification just from the X-ray? Well, you can find loose bodies on the CT scan. ignoring these loose bodies, you would not have a congruent hip. You would get early arthritis. You would miss out on articular impaction, which you have to deal with and have to reduce during your surgery. Again, would impact your reduction and your outcome. You would miss on femoral head damage. There might not be a lot you can do about femoral head damage during surgery, but it is a poor predictor of prognosis. Maybe if you've got femoral head damage in a more elderly patient, you might consider a hip replacement straight away. And it helps, of course, in surgical planning, particularly the 3D CT scans. Now, what I want to do now is I want to take this a bit from being a boring lecture to you trying to make sense of this. Now, I know that if any of you are presented with these x-rays in the exam, they won't rush to the classification. They would say this is an acetabular fracture, this is a high energy injury. I would treat him according to ATLS, we know associated injuries, trauma CT scan, mention your concerns and so and so and so, but you then might be probed into commenting on this fracture. And I just want someone who would volunteer just with me. We'll try to go step by step. I'll be guiding you, so I'm not grilling you or anything. What lines do you think are sort of disrupted here? And what do you think this type of fracture is? You are not expected to know everything from a plain X-ray, but you are expected to look smart in the exam if you're asked this question. So if Abdullah or someone would help me, sort of anyone, if they would raise their hand. Yeah.
So Muhammad Ansari has volunteered for this, and he's unmuted.
Okay, Muhammad, are you with me?
Yeah, I'm here.
Okay, Muhammad, what do you think? What do you think about the iliopectineal line here?
Iliopectineal line is disrupted here.
Yes.
And ilioischial line is also disrupted.
Yeah.
So by definition, both columns are broken.
Okay.
Both columns are fractured.
Yes, that's correct. So both columns are fractured. So what fractures have both columns involved in them?
Transverse fracture.
Yeah.
Could be transverse fracture, and if I see there is no pubic bone fracture, so I can say that this is not T fracture. And
yeah.
Then the dome is attached to the iliac bone, so it is not both column fracture. It looks like T fracture to me.
Okay.
Transverse fracture.
Sorry, can you say again?
It looks like transverse fracture to me.
Yes, perfect. That's you very well done. I mean, what Muhammad did was very smart. So he looked at the ilioischial line disrupted, iliopectineal line disrupted. So he thought of an algorithm in his mind, which we'll talk about later. It isn't clear. There might be here a very small pubic bone fracture here.
Yeah.
So this is a T. But let's look at the X-ray again, and let's look at these lines. We've got the iliopectineal line disrupted. We've got the ilioischial line disrupted. We've got the anterior wall disrupted, and we've got the posterior wall disrupted. So we've got everything disrupted. And we have one fracture line going from back to front. So if you've got the anterior column and the posterior column, both of them disrupted, you basically have four possibilities, which is what Muhammad just pointed out. It could be a both column fractures, but the dome is still attached to the axial skeleton, so it's not a both column fracture. It could be a transverse fracture, which is one fracture line going through all of the acetabulum from front to back, which looks like it is the case. But before committing to saying this is a transverse fracture, look at the pubic bone. If that's fractured, then it is a T. This X-ray in particular here might not be that clear. It showed more on the CT scan, but yes, this is a T. No one's going to blame you in the exam if you don't see it and you say this is a transverse fracture. All you have is a plain X-ray, and look at the amount of information you have given the examiner by now. And I think that's all what you need to know for the FRCS Viva. Yes, it could be a anterior column posterior transverse. It's not in this case, but I would put these as the last on my differentials for the FRCS. If you look at the CT scan, it's looking more like a transverse from front to back, but when you really concentrate, there is a small fracture line there, and that's why it's a T fracture. But these, whether this is a T or this is a transverse, we're talking at a very high level of sophistication and very high level of you can say academic sort of purposes. So I think that's a perfect answer. Thank you, Mohammed. If someone would like to have a go on this one.
It is Al Gawadi now, and I am going to mute him. Here you go.
I will go ahead. Can you hear me?
Yes, Walid, how are you?
I'm good. So, do you want to start? What do you think about the iliopectineal line here?
Iliopectineal line is disrupted as well as the ilioischial line.
Yes.
However, it is minimal disruption, very minimal displacement.
I agree. So you've got the iliopectineal line disrupted. So the way you would talk, you got the iliopectineal line denoting a fracture in the anterior column. I've got the ilioischial line denoting a fracture in the posterior column. So what are you thinking now that you've got two columns disrupted?
So either a both column or a T or a transverse fracture or anterior column, the posterior hemitransverse.
Yeah.
If we look to the obturator foramen, we will find it is intact also, so we exclude the T fracture. If we look to the dome of the acetabulum, it is still connected to the axial skeleton, so we exclude both column fracture.
Yeah.
If we look to the continuation of the inferior part of the inferior pubic ramus, we will find that the posterior wall is intact, so I suspect it is transverse fracture.
Yes, and I agree with your assessments. You've got the iliopectineal line disrupted, you've got the ilioischial line disrupted, you've got the posterior wall disrupted, anterior wall disrupted, you've got basically one fracture line going from top to bottom. Dome is still attached to the axial skeleton, no fracture in the pubic bone, and I think this is a transverse fracture. If you look at the oblique views here, again, this is the iliac oblique view where you see the ilioischial line, and you can see that it is disrupted posterior column, and you see the iliopectineal line here on the obturator view, again disrupted, and as Mohammed Gawadi said, it's minimal disruption. You won't be going into all of these details in the FRCS. This is probably where Mohammed stopped. This is where where you will be scoring a 7 or an 8 in the exam, and that's as far as you can go. They can then suggest what sort of treatment you might suggest for the patient. Okay, third case, if anyone else wants to have a go.
We have a Nishant, and I will free him in a second. Here we go.
Yes.
Okay, Nishant, hi. Can you hear me?
So in this fracture, the ilio seems to be.
So look at your lines, Nishant. So you've got your iliopectineal line, your ilioischial line. Do you have any worries about these lines?
No, so iliopectineal line looks intact.
Yeah.
Ilioischial line again seems to be intact.
Okay. What about the walls?
So the anterior wall, I can't see very clearly, but it seems to be disrupted. And the posterior wall definitely is disrupted.
Definitely disrupted. Okay. What about the main sort of striking feature on the X-ray?
It looks like an inlet view, and I think the joint is non-congruent, so it is definitely subluxed.
Exactly. So this then will take us back to so that's another point, and thank you for pointing that out. Yes, it's very wise to mention these, but don't always try to point out the obvious before you get into sort of the details. So the obvious here is you've got the dislocation. So point that out, and then if you want to look smart and say that this is an isolated posterior wall fracture because the rest of the lines seem to be intact, then do so. And then this will probably then lead to your sort of emergency management, which we sort of mentioned. So that you need to reduce this, how you're going to reduce it, whether it's going to be in A&E. We said we're going to do it in in the theater setting under GA with muscle relaxation. We're going to document the neurovascular status before and after. We're going to comment on the stability, and we're going to put the patient in traction, ideally skeletal traction, after the reduction. Okay, thank you. This was an easy one. Do you want to do one, the next case also? Hello, Nishant.
Yes.
You want to do the next case? I'll just go through this. So this is, again, so this is the one we were just having a look at. You can see on the obturator view how obvious that posterior wall fracture is. And you can then see on the CT scan, you can see the comminution, you can see that the marginal impaction or the articular impaction. So just by looking at this, you would say that definitely poor prognosis here. Okay, you want to, Nishant, go through this?
Yeah, so on this view, the iliopectineal line, the ilioischial line both are disrupted. So anterior and posterior column both fractured. Then the central dislocation. So this, and the posterior wall, the anterior wall, both are disrupted. So central fracture dislocation involving both the columns.
Yeah. What do you think? I mean, now that you have, I mean, you mentioned the obvious, which is very good. You've got central dislocation, and you've got all of the lines disrupted. And what about the pubic bone?
So the inferior pubic rami is fractured, and the dome is still attached to the axial skeleton. So this would be a T-shaped fracture.
Exactly. So that's perfect. So this is a T-shaped fracture with central dislocation. And of course, your concerns here is about that dislocation, about associated sort of pelvic injuries, and about the articular cartilage being exposed and being in direct contact with the edge of the bone. You want to take this to theaters. You want to put a traction pin on it. You want to reduce this as your sort of your emergency management. That's perfect. Thank you. So again, the iliopectineal line was disrupted. Ilioischial line was disrupted. Posterior wall, anterior wall, all were disrupted. We had one fracture line going from top to bottom. But before committing to saying it's a transverse, we had a look at the pubic bone, and that gave it away as being a T fracture. Looking at the oblique views, you would then appreciate that on the obturator view, if you remember, the obturator view is where we see the anterior column, the iliopectineal line, that's disrupted. We see the posterior wall, which is also fractured. Then on the iliac oblique, you see the posterior column, which is fractured, and you see the anterior wall. That's the CT scan. Okay, who's next?
It's Joe.
Joe.
And I will mute him now.
Okay. Hi, Joe.
Hello.
Hi.
Can you hear me now?
Yes, I can now.
Okay, sorry for that.
Okay, Joe. So, what are your thoughts? And just radiological assessment. We're not going to go through the classic exam answer yet.
Okay, so the iliopectineal line, this is disrupted. The ilioischial line is disrupted as well. The so that's the pubic rami, the obturator foramen. I can see that the inferior pubic ramus might be fractured. I'm not sure, but it seems that it's not congruent. Oh, sorry. I would retract.
What about the dome?
The dome is not connected to the iliac bone, so I think that's a both column fracture.
Perfect. And you know, this is probably the most complex fracture that you can get in the exam. And you know, in 20 seconds or so, you managed to identify that this was a both column fracture. It's much easier than you know you might think. You've got an ilioischial line disrupted, ilioischial line disrupted. The dome is not connected.
The dome is disrupted, so it's both column.
The both column fracture. And then if you look at the obliques, you won't get the obliques in the exam, I doubt really, but you've got ilioischial.
This is an iliac view showing the iliac view showing the ilioischial line disruption. So the posterior column is disrupted and the anterior wall disrupted. And this is the obturator view showing the iliopectineal line disrupted, the anterior column disrupted, and the posterior wall disrupted as well.
There's a sign here. I don't know if you've heard about
spur sign.
Exactly. So what is the spur sign? So because the acetabulum is no longer connected to the axial skeleton, when you get this oblique view or lateral view, the acetabulum or the ilium remains intact, and you can see that the rest of the acetabulum has moved.
Moved medially.
Exactly. So then you see the spur of the iliac, and that's another sort of MCQ question there. This is the spur sign. Okay.
Yeah.
Perfect. Okay.
Thank you.
Thank you, Joe.
Thank you.
Yeah. So if you look at the CT scan, you can see that what Joe was saying, it's just not attached anymore to the axial skeleton throughout all of the images. It's disrupted there, and yeah. Basically, you know, one of the things we used to say when is this a both column fracture? There's a fracture everywhere, in the columns, in the walls, everything's broken. So you can see here on the CT 3D how the ilium here is no longer attached to the rest of the pelvis. Okay, who's next?
Next is Atif. Atif, here you go.
Hello?
Yes.
Can you hear me?
Yes.
Yes.
Right, so this is an AP radiograph of the pelvis, which shows a disruption in the iliopectineal line, which is an anterior column fracture.
Yeah.
I think the ilioischial line is intact.
Perfect. Yeah.
There's a fracture in the pubis.
Yeah.
And the dome seems to be intact as well. I can't see any fractures.
I agree.
The anterior column, the anterior wall and the anterior and the posterior wall. I think there's a fracture in the anterior wall, but not the posterior.
Yeah, I mean, I agree. There are these fracture lines which and that's that's how trauma is. Nothing is classic, but you went through them perfect. You managed to see that ilioischial line, which a lot might think it's disrupted, but it's actually there. If you follow the right line, it's going up there, and it's actually intact. And what is broken is the iliopectineal line. It's the anterior column here that's broken. The posterior wall, yes, there is some comminution, but overall, and from the CT scan, which we will be able to get more information from, it turned out to be intact. And the dome was intact, as you mentioned. And then here on the, look at, and to get more of that, the posterior column, this is an iliac view. And can you see the posterior column here?
Yeah.
Yeah, so the posterior column is there. And it is intact, as you said. And then if you go to the obturator view, now you can have a better look at that posterior wall. And what do you think about that posterior wall there?
It still looks to be intact. I can't see any fracture.
Yeah, exactly.
Yeah.
So the anterior column, we know it's broken, iliopectineal line, but the posterior wall looks intact. So basically, you have what's the main fracture that sort of survived all the three views? You think?
So it's a posterior column fracture then.
You mean anterior?
Sorry, anterior column. Yeah.
Anterior column, exactly. It's an anterior column fracture. Oh, thank you. That was very good. Okay, this is the last one, I think. Yeah, case 7.
That's Ghulam next.
Hello. Yeah.
That's hi. Yes. Good. So, do you want to start?
Yes. This is the AP of the pelvis, which I think there is a disruption of the iliopectineal line, but the ischial line is intact.
Okay, this is a very tricky one. I agree, but so let's trace the iliopectineal line. So that's there. That's the iliopectineal line there, and it is broken. What about the ilioischial? If we start from the top of the inferior pubic ramus and follow it, where does that lead? All the way. Yeah.
It is intact.
There. So if usually the ilioischial line would be attached back here. So actually it's broken, but from the top. It's quite deceiving because it looks like as if it's actually attached to this bone here, but it shouldn't be attached to the sort of front of the sacrum. It's actually displaced. So that's the iliopectineal, and that's the ilioischial. And they're broken on the top. It is quite deceiving. I agree, but it is broken. That should be all the way back, attached to the ilium there.
Okay.
Yeah, but again, this is only an X-ray, and you can only get that much information. But what do you think? Okay, so both columns are fractured. What do you think about the dome now?
I think the dome is attached to the axial or to the ilium, and ilium is attached.
It is a poor quality X-ray, but there is something happening there. But again, you can't just see because of the X-ray. But there is something there and there. So there is a suspicion that this is disrupted from the axial. I know it's not the perfect X-ray, and I think what you need to do in the exam is you demonstrate that you have that ability to comment on the lines. You have the differentials in your head, and it's only a CT scan that will confirm whether this fragment we see here is a fracture in the ilium or not. And then here on so this is the posterior column you can see on the iliac view. Is it clear now how that is disrupted?
Yeah. Yes.
Yeah, so that should be reduced all the way back here to the acetabulum, but it's disrupted and it's actually quite displaced. So this is the iliac view showing the ilioischial line disrupted and the anterior wall. And this is the obturator view.
Yes, which also.
Yeah, and that's the iliopectineal line disrupted. And if we remember, we mentioned this sign.
Yes. Yeah.
Yes. Yeah.
So it is both columns fracture with the dome displaced. So it is two columns fracture.
Yes, exactly. Thank you. Thanks a lot.
Thank you.
So I think as you can see, it's this is the CT scan, and you can see here how it is separated from the rest of the skeleton, and you are not going to be expected to be able to classify it just by looking at a quick X-ray in the exam, but you just have to be able, if probed, to demonstrate that the principles of the fracture, the principles of the classification. What's the difference between the anterior, the both column fracture and a transverse fracture? It might sound quite difficult if you're trying to just learn it by heart. Oh, an anterior column is defined as so and so. But once you get the understanding of it, it actually makes a lot of sense, really. And I think that's why I enjoy pelvic and acetabular fractures. Anyways, so these are the fractures. Next, we need to know how to treat them. Well, I mean, I'm not going to go through indications of treatment and so on, and indications of surgical management. These are articular fractures. And in young, active, healthy individuals, you would aim for anatomical reduction. Yes, undisplaced fractures will be treated non-operatively with non-weight bearing and early range of motion and so on. But let's cut straight to the point. And what approaches are we going to do we have with the acetabulum? And this is another sort of tricky bit, another reason why people don't enjoy acetabular fractures that much. We've got a lot of approaches. So we can divide them into sort of categories. We've got the anterior approaches, which include the ilioinguinal and the intrapelvic. The intrapelvic is known by a lot as the modified Stoppa or the Stoppa approach. In pelvic terms, they prefer the term intrapelvic approach rather than the Stoppa. We've got the posterior approaches, which is mainly the Cocker-Langenpick. You could add to it a trochanteric flip to get more exposure. You've got combined approaches, so fractures that need to be tackled in front and back. You could combine the ilioinguinal with the Cocker-Langenpick, or the intrapelvic with the Cocker-Langenpick, and so on. You've got extensile approaches, like the extended iliofemoral, not commonly used, mainly for sort of neglected old fractures and so on, and not really one of the question points in the FRCS exam. How do we choose the approach? Well, there's a lot of details that can go into this, but generally speaking, anterior fractures you treat with anterior approaches, posterior fractures you treat with posterior approaches, and then there are some exceptions and so on. So what are the anterior fractures? The anterior column fracture is treated with an anterior approach, whether it's the intrapelvic or the ilioinguinal, both column fractures. It's mainly anterior. If you remember, the ilium was disrupted from the rest, or the dome was disrupted from the rest of the acetabulum. So your main goal and where you will start treatment would be restoring the continuity of the acetabulum, so that you have to go to the front. You have to go anteriorly for that. Anterior column posterior hemitransverse fracture, which is sort of has a lot of characteristics in common with the both column fracture, again treated with an anterior approach. You've got the posterior approach for the posterior wall, for a posterior column, and a transverse posterior wall because it has a posterior wall in it. What about the transverse? If you just have a transverse, if you remember, we said the transverse is actually one fracture line passing from front to back. So we're actually treating one fracture, and most surgeons would then start posteriorly and fix and reduce and fix it through a posterior approach. But every fracture has its character, and if they feel that the displacement is more anterior than posterior, they might choose to go anterior. So the general consensus is posterior unless the fracture dictates otherwise. A T is a transverse fracture, again split into two. So you remember you had the one fracture line from front to back, and you had a fracture line going down to the pubic bone. So you now have two fractures. Usually you see where the displacement is more, is it front or back? And you start with the more displaced column. Posterior approach for the acetabulum. So we all know the Cocker-Langenpick approach for a total hip replacement. And here the common question in the FRCS is, how is that different? So if you are treating a posterior wall fracture, what changes are you going to do in your approach to that of a total hip replacement? The main difference between a total hip replacement and a posterior wall fracture is that in a posterior wall fracture or in an acetabular fracture, we are still concerned about the blood supply. So we don't want to compromise the blood supply. So the differences are all related to that fact. So the piriformis and the conjoint tendon of the rotators, instead of cutting it flush with the bone, usually with a total hip replacement, you'd want to cut it straight on the bone so you can reattach it to the bone. You can't do that with an acetabular fracture. You want to leave at least a centimeter of tissue near the insertion. Why? Because you want to preserve the ascending branch of the medial circumflex vessel, which passes in that region. So you want to stay away from it because you want to preserve the blood supply. For the same reason, you want to preserve the quadratus femoris muscle, which a lot of us just cut in the hip replacement. The glute max, however, most surgeons would cut the glute max because to get better exposure, and there's no worry about any blood supply coming from the glute max. So that's the main difference. That could be sort of a Viva question or an MCQ one. Okay, then we trochanteric flip, and believe it or not, I mean, I was asked in my FRCS about the trochanteric flip, which I was happy to be asked about the trochanteric flip because, you know, that's my main sort of area of interest, but I was surprised that I was asked about it in the exam. But it's basically, it's a osteotomy of the trochanter, and I'm not going to go into the details. It could be a biplanar, it could be a triplanar osteotomy. The idea is that with the posterior wall, you could, with a posterior approach, with the Cocker-Langenpick, you could get more exposure of some of the anterior wall and the anterior column without having to do a separate anterior incision. And this is part of the surgical dislocation of the hip. So the next step after that is to divide the capsule in a Z-shaped manner and to dislocate the hip, safe surgical dislocation of the hip. One of the approaches you will need to revise for your basic science or for your either other, could be adult pathology or could be trauma viva. Anterior approaches. So we've got two main anterior approaches, the ilioinguinal and the intrapelvic. Won't be able to go through the details again today, but the idea of the ilioinguinal is that it is windows. You have first window, you have a second window, and you have a third window. The first window is the window you usually do, like for an iliac bone graft. The second window is between the vessels and the iliopsoas muscle, and then the third window is medial to the vessels between it and between the conjoint tendon. And maybe the main problem with this exposure was that you see the fracture in windows. You don't see it all in one go. It's a bit of a complex approach. You have to dissect on the vessels, you have to dissect on the spermatic cord, and it's considered to be probably one of the challenging approaches in trauma surgery. And thus, a lot of people have now shifted to the anterior intrapelvic approach, or the modified stop approach, which is a fancier incision. You go between the two recti muscles and you dissect on the extraperitoneal, on the inner surface of the pelvis. Are there differences between in terms of which approach do I choose between the anterior intrapelvic and the ilioinguinal? Technically speaking, yes, there are certain fractures which may be amiable to one approach over the other, but it usually comes down to surgeon preferences. We've got surgeons who are mainly ilioinguinal surgeons, which will treat any fractures with ilioinguinal approach, and we've got surgeons which will do intrapelvic approaches for all of their fractures. I've met surgeons in sort of these pelvic courses where they haven't done ilioinguinal for 15 or 20 years. So it's a surgical choice rather than any particular indication of one over the other. Outcomes, and these may be asked more in an MCQ setting, but we mentioned a lot of these outcomes while going through the lecture today. The main prediction of outcome in pelvic, not in pelvic, but in acetabular fracture is the quality of reduction. And if any of you are familiar with the work by Matra, where he classified the reduction based on the post-operative radiographs into anatomical reduction, where you reduced within 1 millimeter of anatomical position, to imperfect, which is 1 to 3 millimeters of displacement, and poor, which is more than 3 millimeters of displacement. And they demonstrated that the outcome depends mainly on the reduction. Of course, there are other factors. We mentioned the fracture type, and this might be a bit surprising, but a lot would think that a fracture like the both column fracture would have a worse prognosis, but actually the both column fracture has a better prognosis than a lot of the other acetabular fractures, particularly more than the posterior wall fracture. The both column fracture, because the whole acetabulum shifts together, so it has this concept called secondary congruity. If you remember, we said that the acetabulum is floating. It's floating, but it's sort of floating together. That's the idea of secondary congruity that happens in these both column fractures. Whereas a posterior wall fracture, as simple as it might sound, is associated with hip dislocation, so that's AVN, associated with marginal impaction, with comminution. So posterior wall fracture would have much worse outcomes than a both column fracture. And I think I remember I got also that in my MCQ exam, asking about which fracture has the worst prognosis. Fracture pattern goes without saying, the more comminuted it is, the more articular impaction there is, then the worse the fracture is. Articular impaction, you'd find it in the posterior wall fractures and in the dome. So the dome itself could also be impacted. You could appreciate that on a CT scan rather than an X-ray. Patient age also plays a role, and we talked about these geriatric acetabular fractures are a totally different group of fractures and not to be confused with them. It won't really, matter if, what matters is MDT input. Is the patient fit for surgery? Can we get him up and moving? Shall we think of fixation? Would this patient tolerate fixation and protected weight bearing for a while or non-weight bearing for a while? Or would this patient need to go straight for a hip replacement so we can get them up and moving as quickly as possible? Delay to surgery more than 3 weeks is considered also to be one of the poor outcomes. We're fortunate here in the UK, that's not a common thing, but in other places it is a common problem. Complications, number one is arthritis. Numbers could vary between 20% and some studies saying 40%. Again, depends on the quality of reduction. AVN, more common with posterior wall fractures and dislocations, sciatic nerve injury. And here is another sort of MCQ bit where they ask about the different anatomical variations of the, or you could be asked in the Viva, if you talk about the complications, what are the different anatomical variations of the sciatic nerve? VTE, and this is a very important point because I have witnessed Viva scenarios about acetabular fractures being shifted all the way from that to a VTE scenario. Most major trauma centers would have a VTE protocol for dealing with these fractures. Where I did my fellowship in Bristol, they used to do preoperative duplex scannings for these patients. They used to do postoperative duplex scannings 5 days or before discharge. And they used to put them on enoxaparin for 28 days. Different hospitals have different protocols, different major trauma centers have different protocols. It's important that you're aware of this. It is a problem with pelvic and acetabular fractures. It's a major cause of morbidity and mortality in these fractures. You should be aware of a protocol in case the Viva then shifts from being an acetabular fracture, shifts towards being a VTE sort of Viva. HO, and it's, as we would expect, it's more common with the extensile approaches than the posterior approach. So surprisingly, it's not common with the ilioinguinal or the intrapelvic, but it is common with the posterior approach. Again, this is another sort of Viva thing about the evidence of using anti-inflammatories, the evidence of using radiation as a prophylaxis on this HO. And I think some centers here in the UK, and I think as far as I am aware, that I don't want to name the center because I'm not 100% sure, they do, for posterior approaches, they do give routine low dose radiation to the patients for prophylaxis against HO. Okay, I think I've covered the things I want to cover, and I hope that I made this a bit more easier, and thank you.
Thank you very much, Walid. It was thorough, yet interesting and exciting, and I think everyone enjoyed listening to you. I certainly did. I'll leave you to have a glass of water while we prepare the questions. While we talk about that, guys, if you are interested in the Viva, I'm not sure we have enough time to ask many of you, but if you do, please mention that to us. You know about the upcoming Viva course. I think we might still have 1 or 2 places left. If you are interested, please let us know and we will try and book you a place. In fact, you go to the link and you book yourself. Thirdly, for the lecture, you know that this will be on YouTube. As soon as we can, we will put it on YouTube for you guys. I think it deserves a second and maybe a third listen while looking at different x-rays to try and work it out for yourself. And kudos to all those who volunteered for the interactive part. I think you've probably secured better learning than anyone who was just sitting there and listening. Fine. So in a minute, we will be talking about the questions. Before that, we welcome 2 other mentors who will be joining us for the Viva. We've got Sahib and Abid who will be doing some of the questions for that. Stratus has asked, is there a possibility that you could go through a choice of surgical approaches briefly? You've mentioned that. And when it comes down to surgical management, that's it. Next is Cashewnut. Said about central dislocation, will we apply lateral skeletal traction as primary measure or just linear traction?
No, I mean, originally when this was the main method of management, I mean, speaking to sort of a lot of my senior colleagues, when they were treating these non-operatively, they did use lateral traction, but that's not what we do now. This is a temporary measure that you do it for 28, 48 hours until the patient stabilizes. So just skeletal traction, the standard above the knee, and you put weight until you feel that the head is no longer in contact with the edge of the bone until you refer for definitive management.
So let's take that step by step, because this could be a juicy question for the exam. Okay, if that is the case, then any DGH surgeon should know how to apply it. Can you take us through it in more detail? So where do you put the pins? How much weight do you put? How long do you leave that for? And is there any special thing to put for the pin itself, like a care?
So number one, this is of course done ideally in theaters. It is done under a GA. In extreme cases, you could argue it could be done locally, but for exam and for the right answer, this is done under GA. This is done under fluoroscopic guidance. The traction pin is put at the distal femur above the femoral condyles. And this is another bit, and you need to check its insertion with the fluoroscopy. The main problem with these pins is that if you put them too close to the joint, you can cause a fracture in the distal femur. If you put them on the condyles, you will be disrupting the knee joint. Remember the attachments of the knee capsule. So the knee capsule goes around the condyle. So if you go into the condyles, you're potentially compromising the knee joint itself. So you want to go on the distal femur. And then another sort of question is, do you go from medial to lateral or do you go from lateral to medial? Well, because we're worried about the vessels medially, so you do your small incision medially, you put in an instrument and go through the muscles. You go from medial to lateral, because if you're worried about something medially, you don't go blindly through it. And then you start with as low as you can. You put 2 kilos to begin with. You could put 3 kilos. You keep on adding them until you feel that you have dislodged the head of the femur from the edges of the bone, and monitor the patient afterwards, and that's it. And,
okay, just a follow-on question. Atif was asking, what if the dislocation doesn't reduce with skeletal traction?
So the central dislocation, you don't want to reduce it. You might not be able to get it out of the pelvis. You want to disimpact it from the bone. You just don't want that articular cartilage to be in contact with rough bony edges in the fracture. So you don't compromise the cartilage, but you might not be able to bring it back to where it normally was.
Excellent. Thank you very much. That was very clear. Next, Omar is asking, if possible, some explanation of the tectal, supratectal, and juxtatectal fractures and the significance of identifying them.
Yeah, so
that's
I don't
something
think
that we need to know about for the exam.
No, I don't think you need it. These are the variants of the transverse fractures. And yes, the higher you go, the more challenging it could be, and the different approaches you can use. That's very technical, and that's definitely not.
Let's leave it there then, and let's confuse. I mean, it's a big topic. One was asking, can you elaborate on the secondary congruence and roof arc angles? So you mentioned something about the secondary congruence. Would you like to talk about the roof angles, roof arc angles?
So the roof angles, again, it's not in the scope of the FRCS. Roof angles is basically measuring the displacement of the roof on the 3 views, the AP and the iliac and obturator oblique, and therefore sort of outcome purposes to look at the different fractures and different outcomes. It's beyond definitely the scope of the exam. The secondary congruence, yes, might not be asked directly in the exam, but that is the reason why both column fractures might have better prognosis than other fractures, is because although the fracture is displaced as a whole, yet it is congruent. So it is a secondary congruent. The joint is disrupted, but as a whole, the head with the fracture becomes congruent on its own, away from the rest of the axial skeleton.
Yeah, as in the articular surface itself is separated from everything, but it is intact to itself.
Yes, exactly.
Okay. Now, Osama was asking about the acetabular roof angle and how to measure it. I think the best thing forward for that is to see how it is done on a picture rather than someone talking about it, because
Yes,
it's difficult to demonstrate by talk.
I mean, we've done it and done it on studies, but these are there. It's because now we don't use plain X-rays to look at outcomes. We use CT scans, so it's becoming a very academic thing. It was described by Mehta in the early 90s. It's a very specialized thing when you're comparing outcomes between different fractures. I've not heard of anyone being asked about it either on the MCQ or in the Viva. And I highly doubt this is even relevant now to modern established.
Leave it at there then. Ahmed was asking in which type of fracture you may have secondary congruency. You've mentioned that.
Yeah.
And Berivan was asking what sort of indications for percutaneous column screws.
Yeah, so again, you know, surgical details, they could go on forever. But if you remember, like when we mentioned the transverse and the T, we said with them, you could start with a T fracture. You start with the one column which is more displaced. So let's say in a T fracture, the anterior column is more displaced. You fix it with open surgery, and then you might fix the posterior column percutaneously. And that goes with any fracture. You could do a both column fracture where you reduce the anterior column and fix it with a plate, and then you could do the posterior column percutaneously. Remember that fracture we had when I think it goes Gowedi, who said that this fracture is minimally displaced? A fracture like that, you could argue someone could try percutaneously fixing it. Again, you know, a bit too advanced, I think, for the FRCS. I don't think we'll go into how you will fix it and what's your choice of implant. Will you do it percutaneously? It's just beyond the scope of the FRCS.
Thank you very much. I mean, they've injured. Sorry?
Not something a DGH consultant is expecting.
Absolutely, absolutely. Guys, cover your bases well. Make sure that there are no holes in the things that will fail you. I'm not saying these questions shouldn't be asked. I'm glad you are asking them. It shows that you are interested and you've learned a lot from this topic. But the idea is try and make sure that all the bases is covered across the curriculum before you go to the next level. And I'm saying this for people who are shocked by these questions. They feel, oh God, is this important? Or I don't know these, I'm going to fail. No, cover the bases well and then talk about these if you have time. Last question is from Mohammed. He says, with the availability of the CT, do we need the Dudet views as well? And I think this is the biggest debate we have between pelvic surgeons and DGHs all over the country, I believe. Wherever I go, this is the question. We send the patient to the pelvic team and they always insist on having a Dudet views. And the argument locally is, guys, you are going to have a CT. We provided you with a 3-dimensional CT. Why do you still want a Dudet?
I think it's, yeah, I mean, it's not a question that would be asked in the FRCS, but just, you know, for your knowledge, the reason is when you are reducing the fracture during the surgery, you don't use a CT scan during the surgery, do you? You use your AP and oblique views. So if you have your preoperative on screen with your Dudet views and you want to see if you've actually managed to reduce that fracture, you want to see where that fracture is, you're going to compare it with the Dudet views. You're not going to be comparing it to the CT. It's the same concept when you're an orthopedic registrar and the radiologist tells you, you have a CT of the tibial plateau fracture. Why do you need an X-ray? You know, it's the same concept. Well, I have a CT, which gives me all the details, but I still want an X-ray because when I operate, that will be my reference, not the CT.
Absolutely. And I'm going to throw a little controversy in now for you, Walid. What's your take on primary arthroplasty in acetabular fractures?
Yes, so that's very good, and that's, I mean, I did want to try to fit this in the lecture, but then I felt it was a bit too much. But with the increase of the geriatric acetabular fractures, there is a huge role now for it. And there's talk about what we call a fix and replace, whereas you stabilize the columns without aiming for anatomical reduction. So it's a much less morbid surgery in an 8-year-old or so ever, and you just want to get him up and moving. You put a plate on the anterior column, just get some stability, and then you you put the total hip replacement in, and you fix it well as if it's a revision scenario. So you put screws and all over the socket, and you allow early mobilization. The study from St. George's, they compared doing them acutely, doing these total hip replacements acutely versus trying to fix it and then coming back in 6 months or so and doing the replacement. Then they found that it was double the infection rate if you did it in a 2-stage procedure. So if you think that that patient is not going to do well with just a fixation, it is much less morbidity to do an acute total hip replacement rather than a delayed total hip replacement.
That's good. Is there a study at the moment going on, multi-center study?
Yes, there is. There was a randomized, but that unfortunately I had left Bristol by then, but it's part of them. They're doing a multi-centric studies between acute hip replacement versus fixation in the geriatric population. I'm not aware of the details. There's also talk about using the cone implant. So instead of even having to think about fixing the columns, just putting the cone into the ilium, and that there was a study on that in the BJJ last year, I think from Northern Ireland, and they had very good outcomes. Again, very quick sort of procedure, get the patient up and moving. Again, it's a totally different category of patient, and don't get caught off in the viva. I haven't heard of anyone yet being questioned about a geriatric acetabular fracture in a viva, but with the numbers increasing, that might be a topic in the viva.
As it is a RCT in major trauma centers, I think this is probably a valid question, as it's they may not expect you to know the answer, but to know that that's an option for the geriatric population.
I agree.
Excellent. Well, this was an excellent talk, excellent questions from the audience, and very informative. I really enjoyed that, and I will be stopping the recording now.